This article, from authors at the Washington University School of Medicine in St. Louis, Missouri, reviews the spectrum of congenital and acquired vascular anomalies of the pediatric liver. The paper begins with a review of the normal umbilical vein course and discusses complications of umbilical venous catheterization, including misplaced catheters, umbilical venous perforation, and umbilical venous thrombosis. Moving to the portal venous system, the paper focuses on congenital anomalies, including preduodenal portal vein with or without obstruction, portal vein hypoplasia or atresia, and infradiaphragmatic total anomalous pulmonary venous return. Portal vein thrombosis can be partial or complete and is best initially evaluated with ultrasound. While it can be asymptomatic, patients can present with abdominal pain, ascites, or fever. Chronic portal vein thrombosis is typically diagnosed due to the presence of ascites, encephalopathy, varices, and upper gastrointestinal bleeding. Extrahepatic portal vein obstruction in children is the most common cause of portal hypertension in the developing world and the second most common cause in the Western world. The treatment of choice is the performance of a mesocaval or Rex shunt. Hepatic arterial anatomic variants are seen in 50% of the population, the most common reflecting a replaced or accessory right hepatic artery. Hepatic artery aneurysms due to fibromuscular dysplasia, as seen in NF1, medium vessel vasculitis, such as Kawasaki disease and polyarteritis nodosa, or mycotic aneurysms, are best depicted on multi-detector CT angiography. Hepatic vein variants can be appreciated on cross-sectional studies performed for other indications. The most common acquired hepatic venous disorders are Budd-Chiari syndrome and sinusoidal obstruction syndrome, or SOS. In Budd-Chiari, intraluminal thrombus or webs or extrinsic compression results in IVC obstruction. In SOS, previously termed hepatic veno-occlusive disease, obstruction results from myeloablative chemotherapy, alkaloid chemicals, and complicating the ingestion of herbal teas and foods. This diagnosis can usually be suggested on Doppler ultrasound of the liver. Hepatic vascular shunts, as seen in hereditary hemorrhagic telangiectasia, are relatively uncommon in children, but present as telangiectasies, best appreciated on early phase dynamic CT or MRI. Finally, arterial portal shunts and congenital portosystemic shunts are discussed and illustrated. In particular, children with congenital portosystemic shunts are prone to encephalopathy and to the development of several hepatic vascular anomalies and tumors, as illustrated in several cases featured at the end of the article.